So I should stop sharing?
Yes. So we will switch gear now to our panel discussion. And our panelists today, if I can ask you to open your video cams. We have here Dr. Mohammad Nahedh. He's the acting head of Oncology Pharmacy at King Faisal Specialist Hospital and Research Center. We have Dr. Abdulaziz BinObaid, Oncology Pharmacy Supervisor at the National Guard Health Fair, Jeddah. We have Dr. Khalid Al-Huwaish. He's a senior pharmacist and chemotherapy preparation specialist at King Fahd Specialist Hospital in Dammam. Also, we have Dr. Salman Alabdali, who is a pharmacist in King Fahd Hospital in Medina and overseeing the Oncology Pharmacy Operations there. Welcome to all our panelists. I will make sure that I let you guys open the cam. Awesome. Okay, so I'll start my first question, and I will elaborate on, start our panel discussion on asking Dr. Mohammad Nahedh about the operational perspective of COVID-19 in a huge hospital like King Faisal Specialized Hospital. So if you can just brief us on how are you optimizing patient access to pharmaceutical care, especially when it comes to pharmacy operational challenges that you have faced during the pandemic nowadays.
Sure. Thank you very much, Nora, for this opportunity. Thank you very much, SOPA, for the opportunity. Thank you very much, Mansour, for the excellent talk. So I'm going to share an experience that we had and focus on the ambulatory care, because that's where the challenge is. We didn't have much challenges in the inpatient setting as much as in the ambulatory care. So when our clinics closed and converted to virtual clinics and phone clinics, and with the huge volume that we have, we know that we're going to have a huge problem with access to the pharmaceutical care. So we've adopted several strategies, and I can share some of them. One of the things that we had at our hospital is a call center. We had an existing call center way back, but that was ran by nurses because most of the calls prior to COVID were non-medication related. But now with the COVID crisis, we know that everybody wants to get a hold of the pharmacy, either to track their medications or some questions or etc. So we integrated a pharmacist in the call center to triage and help these questions and have a connection between that pharmacist and the senior pharmacist in different pharmacies. They used a WhatsApp group, which was very helpful. They also have a daily report and documentation to track what are the most frequently questions that they get asked. So if there is a problem in the process that we can manage. So and that helped and was able to capture a lot of calls from patients. So call center was number one. Number two, we've opened a drive-through pharmacy. Basically, it's another dispensing site for the hospital where the patients who live in Riyadh can just stop by the pharmacy and get their medications after receiving a text message saying that your medication has been processed. You can go to this pharmacy. These are the operation hours. Because one thing that we have a major challenge is that every day we have around 6,000 patients come into the clinic. So imagine you have 6,000 every day coming to the clinic, and all of a sudden you tell them stay at home and we're gonna take care of you. So that was a huge problem. And most of the patients live outside of Riyadh. So we had to also maximize the utilization of the mail service, both DHL and SAMHSA, and they also have a difficulty coping with our volume, to a point where we had to contract with other carrier just to cope with the demand. The other thing that we did also, we assigned specific pharmacists in the outpatient pharmacy to each service. So we've had a very close communication with the hematology bone marrow transplant, and we assign a pharmacist for them. So if they have a questions, or if their patient had a question, or there's a problem with their prescription, this is your pharmacist. Breast cancer, this is your pharmacist. Medical oncology, that's your pharmacist. Solid organ transplant, liver transplant, that's your pharmacist. Again, to facilitate the communication between the nurses, medical, and also the patients. The other thing that we did for the infusion patients who are on active chemotherapy and were stuck in other towns in the northern region or southern region, we had some sort of collaboration with the MOH hospitals, and we worked very closely with the local pharmacists, shipping their medications if they don't have it, and also if they have questions, and if they needed the chemo protocol and they wanted to have some medical questions. So we had to get together, not only pharmacists, but also medical, supply chain management, outreach service, to make sure that we are after these patients. So these are some strategies that we've implemented, but every day we find out there's a problem in the process, and we try to develop and work on or create another strategies, hopefully, so we can make sure that patients have good access to us.
Awesome. Thank you so much for that. My next question will be to Dr. Abdulaziz. And Dr. Abdulaziz, as I said, he's overseeing the National Guard Health Affairs in Jeddah. And I'm hearing a lot about using telemedicine and telepharmacy especially. And Dr. Nahedh just mentioned about delivering the medications, but also Dr. Khan gave us a little bit about providing telemedicine services led by pharmacists to oncology patients. So can you let us know about some of the successful strategies that you adapted at National Guard, and if there were any challenges that you overcome throughout the process? I will unmute you. Give me 1 second. Yes, you can go.
Okay. First, I would like to thank Saudi Oncology Pharmacy Assembly, SOPA, Dr. Mohammad Shamrani, and Chairperson Dr. Nora Alkhuadir for giving me this opportunity to talk about my experience in the National Guard Princess Nora Oncology Center in Jeddah during the COVID-19 pandemic. Actually, we are facing many obstacles related to the COVID-19 pandemic situation. These are mainly related to the medication shortages due to the slowness of the medication supply chain. We have also difficulties for patients to reach our medical facilities. And also we are having difficulties for arranging and for also patient understanding the new care based on the virtual medicine or telemedicine. So before proceeding, let us talk about the concept of the virtual medicine or telemedicine and how we are applying this concept in the National Guard Health Facility in Jeddah. In the beginning of the COVID-19 pandemic, our hospital administrators realized that we must apply a virtual medicine in order to minimize the crowdness, restrict the access to our hospital, and to apply social distancing. And by the way, this is applied for the whole hospital, inpatient and outpatient services. For the outpatient clinic service, all clinics were shut down, similar like King Faisal, except for some specialties like medical, gynecology, and also oncology. Later on, medical and gynecology clinics were moved to the primary care, to the National Guard primary care inside Jeddah. Only the oncology clinics were inside the hospital. Later on, the follow-up oncology clinic moved to be instead of being inside the chemotherapy area, it's moved to the other clinic, other building. So the virtual medicine or telemedicine concept were applied by canceling all patient appointments, and instead of that, physicians were calling patients. Then physician need to specify the level of care the patient need, and if the patient is in a stable condition, physician need to refill the patient medication and refer him to the pharmacy. If the patient needs certain procedure like blood work, X-ray, etc., the physician need to make his referral, then read the result, and then decide. For emergency, patient need to come to the hospital by any way. So this process was applied by oncology plus patient who need to come to the IV chemo infusion unit at the patient scheduled time. This fact was based on the fact that the cancer cannot wait for the corona or COVID-19 or any other situation. And to apply this process, the hospital created a special hotline for patients call. In pharmacy, we had special line for refilling patient medication, and it's same experience like King Faisal. We have a lot of prescription for one day. So later on, the patient were added the hotline to follow up on the refilled medication because of problems comes from the carrier. The oncology department also need to forward the patient information to the oncology pharmacy on daily basis, so we can follow up on patient and follow up on their prescription. So the pharmacy role by receiving or after receiving the prescription was to fill this prescription and to contact the patient again, confirming his phone number, his address. Then the pharmacy need to send these medication using a local carrier. We are having SAMSA. I can say finally the virtual medicine or telemedicine was or is extremely helpful to provide care during the COVID-19 pandemic and to limit access to the hospital and to protect oncology patients from coming to the hospital and have the infection. But the main problem we are facing was the medication delivery. Still was existing one of the main problem because it's depend on the carrier. The carrier, as mentioned by Dr. Mansour and Dr. Mohammad, medication like fridge medication was really problem. Medication like narcotic control was at the beginning problem, and then we are having the agreement with the Ministry of Health, so we can send narcotic control for palliative patient, cancer patients. This is in general, yes. This is our experience.
Thank you so much. I would really love to hear from Dr. Khalid Al-Huwaish about the Eastern region. So as we all experienced and know that the Eastern region is the starting point where everything kind of shut down, and it was unexpected, and it came in a time where not everyone really aware of what's going on. So during that time where everything shut down really quickly, how did you optimize reaching patients in the area? So as I know, King Fahd, a specialist hospital, is the largest one, MOH based. So you have another hospitals around cities in the area. How did you help them, or how did you help them to reach patients and give them their medication, especially those are receiving continuous chemotherapy, IV chemotherapy?
Yes. Assalamu alaikum. Thank you, Dr. Nora, and thank you, SOPA, Dr. Majid, and for Dr. Khan for the presentation. First of all, you know, the starting point, as you said, from the eastern area, from Al-Qatif area exactly, which was under care review. So from the first week, we have a meeting in the hospital to how to give and sending our chemo medication, oral medication also to the patient there, because they need to starting and continue their chemotherapy. First of all, we're starting to reduce the number of patients to the clinics, and even in the care review area and in our hospital, to minimize the contact between all the patients. We create also virtual clinic. We start in the Qatif exactly before Al-Hassa. Our patient going to the Al-Qatif hospital in private sector, really. Our Ministry of Health make a contract with them to have a unit there to give our chemo and our oral chemo medication, IV and chemo medication. It was a small unit, really, cannot be utilized a lot of patients there. So it was okay with us to really to reduce the number of the patient. And all the room there can carry 2 or 3 patients as a maximum. Our area starting by receiving the chemo protocol from the physicians through the system. For sure, we stop all the paperwork in the system. Only we are using the electronic protocol. So no more paperwork by using to avoid contact and contamination by, if there is any contamination by the virus. So all the lab will be checked between the pharmacy and the nurse, because we don't have it in the system. It's only in the private sector. They don't have any link to our medical plus our hospital system. So we double check all the lab results between the clinical pharmacists and our area with the nursing about all the level. After the confirmation, we start to prepare the chemotherapy. We prepare the chemotherapy daily basis after 4 o'clock, except the medication with the limited stability, like 24 hours or less. We prepare it early morning. So this is give a load for us in the pharmacy to come every day early to prepare, to be sent early also to Al-Qatif and Al-Hassa area. You know, to go to the Al-Qatif area, you need to have also a permission from a ministry to go inside. Also, you need to go to Al-Hassa area, which is around 2 hours from our hospital. So all this need to be arranged early. The most important, it was really to send the medication completely to avoid any missing dosing. Some point we have it there. After we prepare the medication and we send it to the hospital, some patient in the second day, they are not fit. Maybe they have fever, maybe they have some social issue, they cannot come to the hospital. Maybe they don't have the approval by ISMP yet to come to the hospital and take the medication. So this is one of the issue we have it. We prepare the medication and the second day patient not show, or he is not fit for chemo. This is considered as a wastage of the medication. What we do exactly, as Dr. Mansour said in his presentation, we follow the guideline. We shift most of our patients to subcut, especially for trastuzumab. For rituximab, some of the patients who is really fit to be, there is no reaction for them, they are also shifted for rituximab. For also, as he said, for nivolumab, the same situation. All this one to reduce the number who will go to the hospital. Our IV preparation during the COVID, it was for curve unit around 900 patients for both area, Al-Hassa and Al-Qatif. For the oral chemotherapy, it was reached up to 700 prescription. For the oral chemotherapy or oral medication sent for that area, around 3,000 prescription. The point for us to send to the care view, like Al-Qatif area, it was very difficult to send. The SIMSA issue, they cannot go on site.
Mm-hmm.
What we do, we have our staff. There is some from the pharmacy staff. They are really live in Al-Qatif. So we send the medication by ourselves. One of our team, Dr. Shahid, thank for him. Really, he's taking the medication every day from our hospital to Al-Qatif gate. And Dr. Layla from Al-Qatif inside, she came to the gate of Al-Qatif to collect the medication from him. This is happening every day. And then the second day, Dr. Layla called all the patients from the dispensary hospital, Al-Rida, it's MOH, to come to the Al-Rida hospital dispensary to collect all the chemo medication. It was really very difficult, but alhamdulillah, we do it well. Now it's open. Al-Qatif, they can come to our hospital, but really we are not recommended for all of them to come because we are still, now we are sending with telemedicine. SIMSA now they can take the medication to there.
That's amazing.
That's it from us.
That's teamwork, and it was nice that everyone got into providing care to patients, especially during that hard time. So it's amazing to hear it, and it makes me feel proud, actually. Thank you so much, Dr. Khalid. Dr. Salman, as working in Medina in one of the MOH hospitals over there, and as you know, our patients usually get referred to major cities like Riyadh or Jeddah or Dammam to get their chemotherapy. However, in such a situation, as all of us just mentioned, they are not able to fly to different areas around Saudi to get their therapy. So I'm curious to know, how did you make sure that you manage and continue therapy to those patients in your region, knowingly that they started somewhere else?
Yes, thank you, Dr. Nora. First, I'd like to thank the SOPA for the invitation and Dr. Mansour for the nice presentation as usual. And thank you for the question. In addition to the medical cities, there are almost 9 oncology centers and departments belongs to the Ministry of Health. And patients whom were affected by the pandemic curfew, I can in a way classify them to 2 groups. First are the patients whom were on chemotherapy, and the other group patients whom were following for the palliative care. And most of palliative care patients were on a narcotic for cancer pain management. And in this regard, as Dr. Abdulaziz BinObaid mentioned, that we got the approval from the Ministry of Health and from the Saudi FDA to send all narcotic to the regions. And assigned pharmacists in the regions did communicate with patients and deliver their medication. Regarding to the patients who were on oncology modality of treatment, we were lucky since most of those patients were on conventional chemotherapy, which are already registered in Ministry of Health formulary. So all these patients, most of them received their treatment on time, unless that the patient whom were we decide, and oncologists and hematologists decide to follow the international recommendation for the guideline of the acceptable delay time for initiation of chemotherapy. And just I want to mention that have we had challenges? Yes. One of these challenges actually the overbooking to the infusion center, since the patient referred to the higher center and back to their regions, considered about 10% of ongoing patient in the regions. But after we following the guideline for the acceptable time for delay chemotherapy, and also for patient safety, not only for to solve the overbooking, we can manage this issue. The other issue was some misinformation regarding to the patient information, actually, like patient previous lines of chemotherapy and some laboratory result that can play a significant role to decide either to continue to change the chemotherapy, but by the effective communication actually between the pharmacy and physicians, we solve this issue. So I can guarantee that all patients continue their treatment in their region.
I think I'm muting myself now. So basically you contacted the other hospitals to know exactly where did that patient reach in their treatment plan, and you continued from there because all of those medications fortunately are registered in a March. That's what I understood.
Yeah, exactly. And all this medication registered in Ministry of Health. It's available in all regions, and we communicate with our colleagues in higher centers to collect the patient information regarding the previous lines, and that's it.
Awesome, awesome. I will open the mic for all the panelists, and I want to ask a question that I got over here regarding the misinformation or some of rumors that got into your cancer patients, and it affected their healthcare, and how you dealt with those situations.
I can answer this question, Dr. Nora?
Yeah, sure.
Yeah, okay. Some rumors like patient after getting a call from a physician, after the physician contacting the patient, he thinks that this is enough, and he will take care of everything as usual. They think that the physician will take care of everything. Actually, the patient need to contact the pharmacy again to follow up on his medication, or he need to wait until the pharmacy call him and send him the medication. This was misunderstanding by patients. So it's like a rumors, and the patient didn't get his medication because of this. And I want to mention on the Dr. Al-Huwesh about his note about the curfew 24 hours. It is actually need is a mother of invention. In this situation, in the pandemic situation, you need to create new ideas, how to use the opportunities that you have, like SFNI application. You need to educate your patient to use this application to access and to reach the hospital.
Awesome. Thank you so much, Dr. Abdulaziz. We have a question here to Dr. Nahedh, is asking about experience of PMT patients, the stem cell transplant patients. Do you actually delay their transplants, or you give more salvage? How did you manage those during the start of COVID-19?
We still transplant patients. We still do transplant patients, especially for those who have malignant disease. Those who have benign diseases, sickle cell anemia, for example, or thalassemia, their transplant can be delayed.
So usually you prioritize, and those who have like sickle cell or some situations that you can just delay, you will delay those. And then the ones, as we know, leukemia patients and so on, you will definitely transplant them.
Yes, and our unit's still full, and we still need more beds to transplant patients actually, and we still, as you mentioned, we still salvage patients. We try to give one cycle of HiDAC to consolidate the remission. But yes, for leukemia, I think the risk is way higher than COVID-19 actually.
Okay, there's a question here. It's a little bit pessimistic though. I don't know if anyone had that situation. Sarah is asking if healthcare providers got COVID-19, do you actually delay all patients and shut down the oncology department, or what was the situation? We've never had that, and I don't know if anyone experienced that.
Can you say that one more time, Nora?
She's asking if a healthcare provider in your oncology department or oncology center gets COVID-19, do you shut actually the whole department and delay therapy, and for how long?
I will ask from our experience also, if you allowed me. We have one nurse, she got COVID-19. She was positive, and really she was using the mask all the time, really. But in that time, we shut down the service in the unit, and all the people contact with him, even from the pharmacy during that time, was under quarantine. They do the swab for them. Alhamdulillah, all of them was negative except the nurse by herself. But the other unit was completely shut down.
Okay. Anyone else had an experience with that? Or I can move to the next question.
Can I answer? Can I say something?
Yeah, welcome.
Yeah, we had similar case in OR, one of orthopedic consultant and one of the OR physician, actually, anesthesia physician. So they were COVID-19 positive, and we had to shut down the OR. And we tested 77 people, and alhamdulillah, all of them came back negative, and then it was clean and then reopened. And actually, in my opinion, I think if it happened in an oncology center, there is no harm of closing the center or infusion center for that particular day, and we need to test all the staff, nurses and physicians, including pharmacy personnel who were in contact with that patient, that person, or that staff. And until we test everybody and the report comes back negative and the area is clean, that should be closed. This is my opinion.
Awesome, thank you, Rahan. There is one question here about if any of the hospitals starting to send chemo and chemo nurses to home to provide home chemotherapy.
No, from our side, no.
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 So this is the recommendation of the SOPA. We have to probably activate it. This is the recommendation of the SOPA. ASCO is encouraging that whenever it's feasible to administer chemotherapy at home by trained nurses or by trained caregivers. I think we're not going into that detail of caregivers giving the chemotherapy. We're not that much smart or educated, or we are much behind in terms of our level of education and understanding about chemotherapy. But perhaps it can be done. I mean, the nurses can visit the patient's home and administer chemotherapy. I think that's doable.
There is one question here, and I think it's going to be our last question for today. It's already 11:30, and it was a great discussion. Thank you all. It's about the experience in each hospital regarding the rota of the duty. Did you separate two teams, or what else did you do to minimize the number of people?
Okay.
Sorry.
Assignment.
Many
I will
of
answer. It's okay. I will answer from our part, please. Really, we divide the team as we can. It was difficult to divide all the team, really. Especially, we have we closed little of the outpatient service, but we have the telemedicine. So the load, most of the load go to the telemedicine. So we still have some people having divided, but the other stuff they don't have.
So did you make the hours shorter and divide the staff?
No, there is the hour shorter for 6 hours during the beginning because there is announcement from OMOH to decrease the time during the work. But some area, like for the chemotherapy area, for me, it was really difficult to divide the stuff in our area. For the technician, I divide for them, but for the pharmacist, it was really difficult. Other area like inpatient, they have good stuff. They divide the area. OBD, they cannot because they shut down the OBD service as outpatient, but they have the telemedicine. So they are responsible for the telemedicine. So it was difficult in some area. It was good for some area, but the other area, it was really difficult.
In our experience, Dr. Nora, the workload during the COVID-19 pandemic was increasing because of the refilling prescription. So the demand of on the pharmacy, the work on the pharmacy was increasing. So, and we try to be flexible, having days off, something like that. In some areas we cannot because we have shortages. We have also some of our staff still in their countries cannot come from their vacations because of the lockdown in their countries.
Thank you so much. Thank you. I think by this we conclude our webinar today. I would thank all our 230 attendees. I saw Dr. Yusuf writing here very nice words regarding he said ليس سؤالا بل فخرا كل ما عملته خلال الجائحة. الصيدلية لهم المهنة. أسأل الله لكم الأجر والمثوبة. آمين يا رب للجميع. Thank you everyone. Thank you Dr. Khan for the great presentation, the panelists for this nice discussion, and for all our attendees. And by that we conclude our webinar for today. Thank you.
Thank you
very much.
Thank you.
Thank you. Thank you.
Thank you so much. Assalamu alaikum.
Wa alaikum assalam. Fi aman Allah.